Okay, I think we'll go ahead and get started. First of all, welcome everybody to this special event. It's hard to believe that we're approaching the end of third term. We're hearing from our students and faculty that the in-person classes are going great. So I want to begin by thanking everyone who has made our hybrid environment possible. We've heard wonderful things from the students and perhaps even more wonderful things from the faculty who are just so delighted to be back in the classroom, if it's only for an hour a week, but it's going well. So thank you. And we look forward to moving into the fourth term. It's also hard to believe that just a year ago this week, the hospital here at Johns Hopkins diagnosed its first COVID case, and we as a school went all virtual. But I want to take this opportunity to thank you all for doing your very best this year. And it was a tough year for so many reasons. And in that vein, I invite you, we'll be sending out a message early tomorrow morning, but I invite you to join our colleagues from the School of Medicine and the School of Nursing and around the university to observe a moment of silence at 12 noon on Friday to honor all those we've lost in this pandemic who are still struggling with the aftermath of the pandemic and all that we have done collectively to secure our future. So thank you, and we'll, as I say, we'll be sending out a message tomorrow morning. So before introducing today's speaker, I'd like to say a little about the significance of earning the rank of professor at the Bloomberg School. As many of you know, these Dean's Lectures are a very, very special occasion, and I do value the opportunity to learn more about the work of our distinguished colleagues. That was the intention for this lecture when this lecture series was established, to provide a forum that highlights the extraordinary work of our newly appointed and promoted professors. It is a long-standing tradition and a significant opportunity to celebrate just some of all the faculty who make this school so great, which we have learned more so than ever over the past year. Achieving the appointment of professor represents incredible accomplishments by our senior faculty and confirms not only the respect and high regard of the school, but importantly, of colleagues across the nation and throughout the world. And this is true more than ever of our honoree today, and that is Dr. Gypsyamber D'Souza. Dr. D'Souza's research focuses on infectious disease epidemiology with a particular focus on HIV and HPV. Much of her work centers on translational epidemiology, and she leads a research program on HPV and related cancers, risk triage, and risk communication. And as many of our faculty have, Amber, over the past year, has used her knowledge and talents in response to the pandemic. In particular, she has worked with organizations and the press to interpret and communicate COVID risk metrics. Amber is currently PI of the MACS Women's Intra-Agency HIV Combined Cohort Study, which is a large multi-site study of HIV in the US. This effort aims to understand and reduce the impact of chronic health conditions that affect people living with HIV. Now, when Dr. D'Souza was merely a doctoral student, she and her collaborators established that oral HPV infections were a cause of oropharyngeal cancer. Their work was cited as one of the top 6 advances in cancer research in 2007 by the American Society of Clinical Oncology. She also spurred research evaluating differences in optimal therapy for HPV-associated and HPV-unassociated head and neck cancer that is transforming current treatment practices. Her seminal New England Journal of Medicine article on this topic has been cited nearly 3,000 times. Dr. D'Souza has over 175 peer-reviewed publications which have appeared in the leading clinical and public health journals. Her contributions to the education mission of the school include teaching one of the core epidemiology methods courses, and she's done so for 10 years. She also serves as a preceptor for the Cancer Epidemiology Prevention and Control Training Grant and is active in mentoring students in the cancer epidemiology track. Her service to the department, the university, and the community is abundant. She currently serves as chair of the EPI Faculty Development and Mentoring Committee and is the co-leader of the viral oncology track for the Cancer Prevention and Control Program in our own cancer center here at Johns Hopkins. She serves as a member of the American Association for Cancer Research COVID-19 and Cancer Task Force and is advisor to the National Cancer Institute's HPV vaccine trial. Dr. D'Souza is a graduate of Swarthmore College in biology and received an MS from the University of Wisconsin in Madison in molecular and cellular biology, followed by an MPH from the University of Texas Health Science Center. She served as senior epidemiology in the Bureau of Epidemiology and the Bureau of STD HIV for the Houston Health Department before deciding to matriculate back into a PhD program, which she did in 2002, and we were fortunate to have her in our PhD program. Upon graduation, she was appointed assistant scientist in the Department of Epidemiology and was subsequently appointed to assistant professor rank following a national search. She was promoted to the rank of full professor last year in 2019. She holds joint appointments in the Departments of International Health, Otolaryngology, and Oncology. In 2020, she was recognized as an ExpertScape World Expert in Papilloma-Viridae, recognizing the top 0.1% of scholars writing about HPV in the past 10 years. Now that is quite an accomplishment. It is my huge pleasure that I extend a warm welcome to Professor Amber D'Souza. Amber?
Thank you so much, Dean McKenzie, for that very, very kind introduction. I'm so excited to join you today to talk about my work in translational epidemiology, advancing understanding and impacting viral disease. When Dean McKenzie asked me to give this talk, especially after having worked from home for a year now, I really reflected on what I wanted to share with you, and it is the translational work, the opportunity to impact disease that when I look back, I am proudest of and is most memorable. And so I'm going to talk to you today about my work and the evolution of my research questions for human papillomavirus, HPV, and for human immunodeficiency virus, HIV, and my work to translate those findings. So when I say translational epidemiology, I'm really speaking about the effective transfer of new knowledge from epidemiologic studies into the planning of disease control and prevention programs and policies. We also talk about applying knowledge from our studies to techniques and tools that address health needs. And one of my passions is communicating knowledge to stakeholders to help inform options and policies. So I thought it would help to put a framework, and I'm going to frame the research that I've done across this spectrum of work that focuses on etiology and discovery, how that leads to translation, and then to implementation. And so examples in the etiology and discovery are research studies such as descriptive epidemiology, natural history studies, and risk factor analysis. Then in translation is studies that involve more biomarker evaluation, risk communication, and creation of tools for stakeholders. And when I speak about stakeholders, there's multiple ones: the public, patients who have those risk factors or those outcomes, providers treating those patients, and the policymakers as well. And implementation in terms of my research usually involves screening and prevention guidelines and affecting those. So throughout this entire spectrum, it is all influenced, of course, by collaboration, which is what enables the quality research to be done and the impact to be had. So that's the framework for what I'm going to talk to you about today. As Dean McKenzie mentioned, a lot of my research focuses on HPV and oropharyngeal cancer. And this started with my PhD research question, where we wanted to look at whether HPV was a cause of oropharyngeal cancer. So I thought it would be useful to have a little background. In 2003, we knew that human papillomavirus was a small circular DNA virus that infects basal cells of the squamous epithelium. And there's over 100 different kinds of HPV, but only a few can cause cancer. HPV-16 causes the majority of HPV-related cancers, but there are several other cancer-causing HPV types, and collectively we call those the oncogenic HPV types. And we knew that HPV caused cervical cancers, vaginal cancers, and anal cancers, but it was unclear at the time whether it had any role in oropharyngeal cancer. And so the background of why those I worked with and myself thought that it could potentially cause oropharyngeal cancer at the time, to give a little background on head and neck cancer, it's a somewhat rare cancer with a lifetime risk of developing it of around 1%. Right now, there's around 50,000 new cases each year, and around 10,000 people die of head and neck cancer each year. And survival is not very high, it's 67% overall. But head and neck cancer involves cancers at multiple different sites throughout the head and neck. And if you look at this picture, you can see this green area at the back of the throat, which is called the oropharynx, and includes cancers here at the base of the tongue. Those cancers in the oropharynx, the trend in those cancers is quite different than the cancers at the other sites. And so, for example, here you can see in yellow, the incidence trend for those oropharyngeal cancers at the back of the throat was steadily increasing, while the incidence trend for oral cavity cancers, and indeed all the other head and neck cancer sites, was decreasing, because those are primarily caused by tobacco and alcohol. And successes in tobacco cessation had led to decreased incidence of these cancers. So the rise in these oropharyngeal cancers was quite notable. And the question was, why was it increasing? It was also known that patients with those oropharyngeal cancers were different than the traditional patients who had head and neck cancer, who were usually older, heavy smokers and drinkers, more likely to be minority patients. And the oropharyngeal cancer population tended to be younger, was more likely to be white and high socioeconomic. Although there was a diversity in all those factors, there were some clear differences. And so I was fortunate enough to work with a team of researchers here, including Maura Gillison, who had this hypothesis that HPV might cause oropharyngeal cancer. And we did a case control study at Johns Hopkins Hospital with 100 oropharyngeal cancer cases and 200 frequency matched controls, and looked at a series of measures for HPV and found that they were strongly associated with odds of oropharyngeal cancer. So when we looked at HPV-16 DNA in exfoliated oral cells, it was associated with a 15-fold increased risk of having oropharyngeal cancer compared to controls. When we looked at blood antibodies to the HPV L1 capsid protein, or the oncoproteins E6 and E7 that disrupt cell cycle, those were strongly associated with odds of oropharyngeal cancer. And when we looked at the behavior that we thought exposed to HPV in the mouth, performing oral sex, the more lifetime oral sexual partners you had, the more likely you were to have oropharyngeal cancer. So HPV infection, HPV biomarkers, and HPV exposure were all associated with odds of oropharyngeal cancer. This, in combination with other molecular work, really helped to prove that HPV was a cause of oropharyngeal cancer. So we followed this work by wanting to understand the natural history of infection. Now that we knew HPV caused these cancers, we wanted to understand the course of infection. So we created a cohort of young adults, 18 to 25-year-olds, in the Baltimore County STD clinics. So this was a higher risk population, since we knew they were there being treated for other sexually transmitted diseases. And we followed them every 3 months, collecting an oral rinse sample and looking at oral HPV infection. And we observed that around 2% of these individuals acquired a new oral HPV infection every month. And the higher the number of oral sexual partners they'd had in the past 3 months, the more likely they were to have acquired a new infection. When we looked at the clearance of these infections, we found that most individuals cleared these infections without any treatment within 6 or 12 months, which is similar to what's known for cervical and anal HPV infection. But some people had persistent infections that had not cleared by the end of the study. We also noticed that persistence was higher in men than in women, which was of interest because these cancers, the rate of oropharyngeal cancers, were higher in men than women. And this data suggested that higher acquisition of oral HPV infection in men than women and decreased clearance of oral HPV infection in men than women could both contribute to the higher cancer rate we were seeing. We next wanted to understand risk factors for oral HPV infection, and we did a series of studies. These studies consistently showed that number of people you performed oral sex on was the primary risk factor for acquiring an oral HPV infection. But as I showed, the majority of people clear these infections quite quickly, but some people don't and progress to cancer. And we wanted to try to understand why, when most people clear it, do other people not? And so we did several studies in this area, and I'm showing one here as an example, where we had seen that people who reported current tobacco use consistently had stronger prevalence of oral HPV infection, and we wondered why. So here we looked at 2 biomarkers for tobacco use, and we saw that even when you didn't use self-reported tobacco use, when you used actual biomarkers that measured the amount of tobacco exposure, cotinine, we saw a very strong association between oral HPV infection and current tobacco use, suggesting that perhaps tobacco-related inflammation made these individuals either more likely to become infected when exposed or less likely to clear these infections once they had them. So that work on the etiology of the cancer led to the next set of questions, where we really tried to translate that information. And it was questions coming in from our participants and from the public that led to our next set of studies that asked, will my spouse get this cancer? Why did I get this cancer? And what's my risk of being infected from the general population? So towards the first question, we had a lot of concern from our patients who had HPV-related oropharyngeal cancer around their infectiousness. Would they transmit it to their grandchildren? What about kissing a family member on the cheek? What about sharing forks and toothbrushes? And we did research to show there was not non-sexual transmission of this infection. They did not need to worry about that. But the patients were still concerned, okay, what about sexual transmission? What about my spouse or long-term partner? Are they at risk for this cancer as well? And this was causing anxiety for a lot of our patients. So we performed another case control study where we looked at patients with oropharyngeal cancer, non-cancer controls, and also enrolled the spouses or partners of the cases. And we looked at a range of HPV biomarkers and saw that here I'm showing antibodies, HPV oncogene antibodies, and you can see that the partners did not have the antibodies to the HPV oncogenes. It was very similar to the controls, suggesting they did not have increased cancer risk. We saw the same thing when we looked at oral HPV infection. The patients were worried that by kissing their spouse, they might have transmitted that infection. We did not see that. So suggesting either it's not transmitted that way, or if it is, the spouses and partners were able to clear those infections effectively, and their own cancer risk remains low. Now, patients were also asking a series of questions around these infections, and there were very few resources at the time to give them. So we created a question and answer pamphlet in lay language that we could provide to patients. And practitioners of head and neck cancer had been trained before the etiology with HPV was established. So that training hadn't included talking about sexual behavior. This was a whole new, area, and not all practitioners were comfortable. So we wrote a article for practitioners with more of the scientific rationale and background, the state of the literature, to help them understand the context to inform those conversations, and included this lay language pamphlet as a figure in that paper that they could print out and provide to their patients. And so this was very exciting project for me because there were not many resources like this at the time, so it became widely used by a wide range of practitioner groups. Other types of translational risk communication work we've done in this area included answering questions for public and practitioner around this area. So in addition to the pamphlet, we also put common questions and answers, we called them the FAQs, on the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center website. And the year that we put up that website, it was one of the most visited websites at the hospital, again, because there just weren't many places to get that kind of information. And the advantage of a website compared to the brochure is, of course, we can keep it updated every year and add additional links. So that has continued to be a really great resource for our patients. We also do multiple different things to try to get this, communicate the information out to the general population. And so here's an example of an NPR interview where we're able to talk in depth about some of the trends and risk factors to the general public. And we also want to communicate, of course, to practitioners. So here's an example of a CDC webinar where it's helping get a state of the science information out to stakeholders and communicate effectively what they need to know. Now, questions were coming in from the public about risk factors. And one day I was reading a Newsweek article that it was just had a great infographic about cholesterol and heart disease. And it described the association so simply and so visually beautifully that I was like, well, that's what we need to do for oral HPV. How can we do it? So we decided to use data from NHANES, which is general population, and to stratify by the risk factors that we knew about to communicate what oral HPV prevalence was among these different risk groups. So for example, it shows that if you're a woman who has never had oral sex or has only had one oral sexual partner, less than 1% of those people have an oncogenic oral HPV infection. It's very low risk. However, if you're a man that has had 5 or more lifetime sexual partners and currently smokes, 15% of men in the general population with those risk factors have an oncogenic oral HPV infection at any one time point. So it helps to stratify. And we know most people with infection will clear those infections and not develop cancer. But of course, the more likely you are to have infection, the more likely you are to be unlucky enough to have it progress. So this helped to communicate that out in a simple visual. We also want to get information together for policymakers. And so one example of that, there is a new Surgeon General's report on oral health, which is coming out, expected out in 2021 this year. And we were very excited to be asked to write the section on sexual activity as a risk factor for HPV infection and oral health, the first time that the role of sexual activity and oral health has been included in that report. So while that work that I just talked about really focused on translation and implementation, of course, it is a cycle. And as we looked at this data, it helped take us back to the exploratory data analysis, where we were observing racial and sex-based disparities, reverse disparities, really, where it was white men having much higher rates of these cancers than women and than racial minorities. We had done work that had shown that some of the differences by race were explained by differences in sexual behavior. People performing oral sex were acquiring these oral HPV infection, and racial differences in those sexual behaviors were explaining some of the racial differences in these trends. But the differences by sex among men and women really were not explained that way. And throughout most of the studies, we were seeing there were very small numbers of women and non-whites to understand what was happening in those groups. So we went back to etiology and discovery and wanted to understand more about what was happening and why there were these disparities in oral HPV infection, in the HPV-related head and neck cancers, and in prognosis. And so I'll give an example from one of these studies. We knew, if you look here on the right, that oropharyngeal cancer among men in the 90s, only a third of these cancers were HPV related. Most of them were being caused by tobacco and alcohol. And the proportion of oropharyngeal cancers among men that are caused by HPV has increased such that the majority of them are now caused by oropharyngeal cancer, now caused by HPV. Now the rate of cancer in women is lower than in men. So in the case population, there's less women than men. But if you look among women who are getting oropharyngeal cancer, as we did in this study, you see the exact same trend, where in the 90s, around a third of them were HPV related, but that has dramatically changed. And now the majority of oropharyngeal cancer in women in the US are HPV related. When we look by race, we see the same thing. So the trend in men is quite clear. The vast majority of oropharyngeal cancer among men is now HPV related, but the same is true in Hispanic, Asians, and Blacks. And although the proportion among Blacks is lower than other races, we still now have 2/3 of all oropharyngeal cancer among Blacks being caused by HPV. So it is now the major cause of oropharyngeal cancer among both men and women of every racial group in the US. Now, there were also policy questions in this area needing data, and part of translational epidemiology is not just providing the answer, but providing it in the way, the language, the format that can be useful to the stakeholders. And so there were several questions around how to screen for oropharyngeal cancer, whether HPV tests that were becoming useful for cervical cancer would have utility for oropharyngeal cancer, and what the impact of HPV vaccine would be. And so we tried to address each of these. Now, the first question, many dentists were being marketed salivary HPV DNA tests. These tests were not FDA approved. They were didn't have a strong peer review literature around them. But we did know that HPV caused oropharyngeal cancer. So many of the dentists being marketed these tests thought, should we use these or not? And some of them were using it. But for the people who in these dental practices who were healthy individuals getting these salivary HPV tests, they were getting a result that there's no treatment for oral HPV, so there's nothing we can give them. And the risk counseling is very unclear because we don't know what their risk for oropharyngeal cancer is. We know most people clear these infections, but the follow-up and monitoring was very unclear. So there was high anxiety with very little benefit. And so we worked with the American Dental Association as part of a panel that was able to review salivary adjuncts in general and provide very clear recommendations. Recommendation 6 here was clear that the ADA panel does not recommend commercially available salivary adjuncts. And this included those HPV tests that were being marketed. This really helps to have kind of a clear, uniform recommendation from a body that was trusted, that could go out through their information distribution system and help the dental community understand that after reviewing all of the evidence, these tests were not shown to be useful. There were also policy questions because the way that we screen for cervical cancer, which is also caused by HPV, had changed dramatically. And the role of HPV in cervical cancer was known well before its role in oropharyngeal cancer. So the research there was ahead of where we were for oropharyngeal cancer. And it's been shown that primary HPV screening for cervical cancer is very useful. And so the question was, could it have that same utility for oropharyngeal cancer? Because there's currently no effective ways to screen for oropharyngeal cancer. So this is one study we did where we took some of those same tests that are FDA approved and known to have utility for cervical cancer, excuse me, and we applied them for oropharyngeal cancer and looked at the sensitivity and specificity. And we saw that there was great specificity for many of these oral rinse tests, but the sensitivity was not good, suggesting limited utility. And when we looked at the HPV antibodies, the blood antibody markers, there was one HPV-16 E6 antibody, which had fairly good sensitivity and good specificity, suggesting it might have utility for screening for oropharyngeal cancer. But this marker has a very low prevalence in the general population. So you would have to screen a very large number of individuals to detect a single positive. So clearly additional research is needed to determine whether or not it might have utility in screening. We also wanted to build on what was known from cervical cancer screening, where a panel of oncogenic HPV is used to screen. But the situation in oropharyngeal cancer is different because the vast majority of the HPV-related oropharyngeal cancers are caused by a single type, HPV-16. So this again had a very simple visual to try to communicate out a clear point, which is that if you look at the patients with HPV-related oropharyngeal cancer on the left, the vast majority are caused by HPV-16, more than 90%. But on the right, if you look in the general population among people who have an oncogenic oral HPV infection, the vast majority of them are not 16, they're other types, other oncogenic types. So if you used an oncogenic HPV probe to identify who's at risk for oropharyngeal cancer, you would be identifying all these people with non-16 types that have a low risk of progression to cancer. And so this supported that if salivary HPV was used for screening at any future point among any subgroup, you wouldn't want to use those other oncogenic types. You would only want to use HPV-16. Now, this is recent work about HPV vaccine, and we wanted to know what the impact of HPV vaccine would be on oropharyngeal cancer. So as a reminder, HPV vaccine was first approved in 2006 for cervical cancer among women, and it was approved soon after that in boys for prevention of anal cancer and genital warts. But the data around the efficacy of the vaccine for oropharyngeal cancer was unclear initially. Additional research came out showing that oral HPV infection was reduced in people who had been vaccinated. Follow-up of people who were in those vaccine trials showed again prevention of oral HPV infection. So just last year in 2020, there was an additional indication added by the FDA for Gardasil 9, the HPV vaccine, to establish that it was shown that it would prevent oropharyngeal cancer. But when will we see that impact? So working with my graduate student, Jenny Zhang, in research that is just now under review, we looked at what that impact would be. And so on the right, you can see here in the younger individuals who are 36 to 45, we are beginning to see people who have been vaccinated. And again, our vaccine program, which targets 11 to 12-year-olds, we had catch-up vaccination up to age 26. And those individuals, now that it has been 10 years since we started a vaccine program, are beginning to age into these ages where the first oropharyngeal cancers are observed. And so we're beginning to see the very small impact. But by 2045, among individuals in this group, we're going to have reduced oropharyngeal cancer by 50% in men and 43% in women in this youngest age group here of the 36 to 45-year-olds. Among older individuals, 45 to 55-year-olds, it takes longer for the people who are vaccinated to age into that age and for us to see benefit there. And of course, older individuals will take even longer. And if our current trends of increasing oropharyngeal cancer incidence continue, so those are currently increasing, and if they continue to increase, what we see for overall oropharyngeal cancer rates on the left is that the benefits that we're getting in these younger age groups are kind of offset by the continuing increases in oropharyngeal cancer among the older individuals. So we're not going to see decreases in the overall oropharyngeal cancer incidence, or they're modest through 2045. Looking at that same data in a slightly different way, here we're showing the number of oropharyngeal cancers prevented by HPV. You can better see how even though vaccination started in women first before it started in men, because men have a higher rate of oropharyngeal cancer, the total number of oropharyngeal cancers prevented in men compared to women, the number, prevented in men will surpass the number prevented in women pretty soon. And the bulk of the benefit is among those younger age groups, but we will begin to see benefit among individuals 56 and older beginning around 2038. Now, I can't speak about all this research in HPV and oropharyngeal cancer without speaking about my mentorship and collaboration in this space. And so I start here. This is my PhD dissertation with my incredible mentorship team of Maura Gillison, Patty Gravitt, Kirti Shah, and David Celentano, which I can't speak enough about how all of these people have influenced my research in this area. And indeed, I have continued to collaborate with many of those same people. Here you see Amy Kramer and Carol Fakhri, both of who trained with the same mentor at different times, with Maura Gillison, who we all trained with. We continue to intersect. These are 5 individuals from Hopkins or Hopkins affiliated, who now this is in 2013 at an additional HPV meeting, you see us intersecting, continuing to share ideas and intersect. And those collaborations have really been so beneficial throughout my career, especially with Dr. Carol Fakhri, shown here, who is at Hopkins with me, and we co-mentor students, have grants and papers, talks together. All of the research I've shared today, she has been involved in leading with me, and the synergy and impact of having such incredible partners amplifies that work. And you can see the amazing students and staff we have had over the years and colleagues in this area. Now, I also want to speak about my research in HIV, and that has been primarily in the MACS and WIHS cohorts. I began working in the MACS data center right after my PhD, where I didn't want to work in a silo by myself. I really craved that collaborative research experience and was so fortunate to join the MACS data center under the tutelage of Lisa Jacobson, Homi Farzadigan, and Alvaro Munoz, and to work with this amazing, amazing group of other faculty at the data center, again, having that opportunity for the synergy in research. And you can see our data center team in the MACS data center there. I was fortunate enough to become the co-PI of the MACS Data Center with Lisa Jacobson and to join the MACS Executive Council, which allowed that synergy not just within our own site, but across the different sites of the study, and to really learn more about how to have translational impact and to do collaborative big science. And change is inevitable. Already working within a large national data center was such an honor. We merged just a few years ago with the WIHS, which is a study of HIV in women, to make the MACS-WIHS combined cohort study. And you can see our amazing data center team there. We now have over 13 study sites. There's 62 people just in our executive council leading across those study sites, and we're about to recruit new participants. So it's been an amazing collaborative opportunity. So in speaking about translational epidemiology and reflecting on working as part of a large cohort study such as this, which has been going on for a really long time, there's an opportunity to kind of work across that translational spectrum. A lot of our research is in etiology and discovery, but there are many opportunities for translation and even some implementation. And I just have, examples here of a few recent papers working in that area. But I'm going to, before I speak about my own translational work in HIV, I wanted to say there's also a lot of administrative work that goes with a data center, but I feel there's been so much value in that time as well. And a lot of my current work in this space, in this cohort, is facilitating collaborative research. So I myself am not seeing things all the way through to their implementation, but I am supporting the scientific operations, and I found tremendous value in that, because setting up the right ways for people to engage, build a study team, ensure you have the right study design to get meaningful answers, and then to ensure the way those results are communicated out is effective and translational, really amplifies the impact and opportunity, and has been a really exciting opportunity to work in a big collaborative group. And so within the MACS-WIHS combined cohort study, I have been researching HPV-related cancers and wanted to highlight a few examples there that tie back into the research that I spoke about in the first part of my talk. So a few examples. As I mentioned, HPV causes several cancers: anal cancer, cervical cancer, and oropharyngeal cancer. We've looked at all of those in the cohort. The main risk factor for anal cancer is receptive anal cancer. So men who is receptive anal sex. So men who have sex with men are at very high risk for anal cancer. It's actually as high or higher than the rate of cervical cancer in women who have never been screened. So we looked at anal cancer risk among men in the MACS, and were able to show that men living with HIV had an increased risk for anal cancer compared to HIV seronegative men, and that risk had actually increased in the recent era with effective heart therapies, because there was no longer the competing risk of mortality from AIDS, and so they had the opportunity to live longer, and therefore were developing higher rates of these cancers. We also looked at cervical cancer among women living with HIV, and this was in any accord, which is a collaboration of multiple HIV cohorts. So we had a very large number of women, and we were able to show that women living with HIV had an increased risk of cervical cancer, and that risk increased with level of immunosuppression. I've also looked at oropharyngeal cancer risk. So in the MACS and WIHS cohorts, we nested a study where we collected oral rinse samples every 6 months for several years to look at oral HPV natural history. And here we were looking at the HPV-16 viral load, so the intensity of that signal and whether it was a predictor of persistence. And you can see here on the right that the individuals with persistent infection, many of them had these very high HPV-16 copy viral loads persistently detected for many years. And indeed, we did have an individual here who, after having this infection detected persistently for 4.5 years, then outside of our study clinically was diagnosed with an incident oropharyngeal cancer. So this provided one of the first times that we had the natural history in a healthy individual of oral HPV infection, and then had that linked with the incident detection of their cancer. On the left, you can see lots of people who cleared their infections, the majority of whom never had a high viral load or had a high viral load at a single time point, but quickly cleared that infection, consistent with what we know about the natural history. So we've been able to look at these different cancers in people living with HIV and understand their increased risk for HPV-related cancer. And that leads to these policy questions of screening in these subgroups. What's the right screening for men who have sex with men for anal cancer? What's the right screening for women living with HIV for cervical cancer? Because often there's very good data on the general population, but for subgroups, it's less clear. And indeed, I was at an HPV meeting where there was a large group of us speaking about HIV, the effect of HIV on HPV, and multiple stakeholders, including people from NIH, were mentioning that it was such a shame there was not enough data on this question, which was really a surprise to me. I was like, there's so many papers. The WIHS alone has, 15 papers in that cohort looking at cervical HPV infection. What do you mean there's not enough data? But I understood later what they meant was the data had not been pulled together in the way they wanted to see it. There were a lot of separate studies and they were looking for it in a different format. So I came back and gave this challenge to another fabulous graduate student, Hillary Robbins, saying we really need to provide this data in the way that will be useful translationally to impact the guidelines. So we came up with this strategy where we would compare a risk benchmark for these new guidelines that had come out in the general population, where women were being told to come back either for 3 years, a year later, or immediate colposcopy. And we said, well, what's the risk of precancer that is warranting those 3 types of return? And let's evaluate when a woman living with HIV would reach that same precancer risk. So here's an example. In this case, we looked among women who had an ascus pap. And you can see that after 3 years, a woman who had an ascus pap and had a high CD4 cell count had a risk level for precancer. It was around 8%, which was the risk level in the general population that warranted a 1-year return. And so that is consistent with what the current recommendation was at the time for women living with HIV, to come back and screen for a year after an ascus pap. So that suggested, ooh, the guidelines are right on. But for a woman who had a lower CD4 cell count, less than 350, you can see their risk of cervical precancer was above 15%, which was the risk level that indicated that woman should go to immediate colposcopy, not come back in a year in the general population, suggesting that that might be more appropriate. And we did that for multiple different scenarios. And what was very exciting for us is we then heard that one of the guiding bodies, the ASCCP, used this paper at their 2019 guideline meetings and used it to then update their recommendations for women living with HIV, which is, of course, such an exciting part of that translational work when you see it help the implementation piece, which was, of course, the goal. We've also done work evaluating how to best screen for anal cancer. As you know, for cervical cancer, cervical paps have been widely used for quite some time. For anal cancer, the utility of anal pap is much less clear. And we did a study in the MACS, so men who have sex with men living with HIV and without, and we showed that the rate of abnormal pap among men who have sex with men is very high. 25% of our seronegative men and 42% of our men living with HIV had an abnormal pap, suggesting very low specificity and that it would not be useful to use for screening, that it had severe limitations for screening. Now, I couldn't finish this talk on translational epidemiology without stopping for a minute to just speak about this year with the coronavirus pandemic and how it has highlighted how critical the need for risk communication and translational epidemiology is. The strangeness as an epidemiologist to open up the New York Times and see an article about what epidemiologists expect, when they say you can get on a plane or hug or do other activities. It's amazing to see our work translate into the common press with such frequency. And it's really been an honor to be part of the school. The risk communication and translational information and impact of, our website and the efforts being done school-wide on coronavirus have been amazing. And indeed, if you speak about having the right collaborators and the right team for impact, very early on during the pandemic, we wanted to put out a free Coursera class with the hope of helping some people get out some information about epidemic curves, surveillance, what we know about outbreaks, hoping that it would be, of help. There's an amazing team here who's very experienced, really helped to get this out super fast. And more than 100,000 people enrolled in the class. It was translated into more than 10 languages, which was just such an insane honor to be part of something that ended up having that much impact. And it's really because of the power of the collaborative team. And I've had that same experience, with other efforts during the pandemic, and how incredible the support infrastructure has been here for supporting translation and trying to get effective communication about epidemiologic thinking out there. So I'm going to pause here or finish here with a huge thank you to my collaborators, my staff, my participants, my family, and I welcome any questions.
Great. So thanks so much, Amber. Maybe you could stop sharing your slides. So, well, that's not important because I forgot we're in a webinar, so we can't see everybody. That's always a shame, but fantastic talk and incredibly important work. And I think this year, as you alluded to, has just underscored the importance of communication about risk to the general public. And the work you're doing in translational epidemiology is just, it's amazing. So I really enjoyed your talk. So please feel free to put your questions, probably easiest to put them in the chat or in the Q&A. I'll try to monitor both. But let me just start with a question, and that is, talking about this year and COVID-19, and did you in your work and compared to the work that you've done previously that you so beautifully laid out for us, have you seen particular challenges in communicating the risks associated with coronavirus and COVID?
Yeah, I think the huge challenge, and again, I haven't worked in this space as much as others, but I've certainly tried, and has been the lack of data early on. And so answering questions when there was not sufficient data and communicating that uncertainty and those changes is challenging for all of us. David Dowdy and I did an NPR interview with people, asking questions about traveling for Thanksgiving. And they, had such good intentions. They're like, well, I'm going to travel, but, when I get off the plane, I'm going to test. So then I can go to the, to see all my relatives. And we're like, no, that's so great that you want to keep people safe and you want to test, but like testing right when you get off the plane isn't going to do it. And so there's a lot of nuances that, I think have just been difficult. We see that with the coronavirus vaccine right now, where people who are vaccinated, it's been unclear how to counsel them what they can and can't do. And this confusion that people have around, well, why do I still have to wear a mask when I'm vaccinated if you're telling me the vaccination is so good? So it's all in the nuances of the messaging. And I think that's a challenge for all of us. Yep.
So very important. So please, I don't see any questions yet, but I'm sure there.
I was just so clear.
There's some questions out there. Yes, of course. So maybe a more general question about translational epidemiology. I think the work you're doing is fairly unique among epidemiologists. Is that fair to say? I think it's growing, but how do we promote this approach? I think the way you lay it out and say, okay, here are the questions the public is having, here are the policies that we need to address, and then you do the research and the epidemiology to support those. But how do we grow that approach?
I mean, there's so many people doing good work in this space, but it is less visible. And it doesn't, feature as prominently on a resume. And you don't, it's harder to say, here are my publications and here are my grants in that area. It's been more difficult, but I see a lot of progress in the ways that we do that. And what we say to students, and what I believe is, you find the right questions, the questions that are interesting to ask, and then you dive in and you ask them and you figure out the ways to put it on your CV or get recognition, or because there's a lot of concerns about, can I get academic credit for that type of work? But if you do a fantastic study and none of your stakeholders know the results, you haven't achieved what you want to achieve. So that second part is something that I think it's hard to figure out initially how to do, but it is just so fulfilling and so important. If you think about the change you want to have and how to get there, it involves going to that next step. And I think there are a lot of people working in that area.
Yep. So here's a question from Priya Dougal. She says, Amber, excellent presentation. We all aspire to translate our work to make it more meaningful. What have been some of the largest challenges in making that happen? Is it with the policymakers, colleagues?
Honestly, I think it's knowing the steps, right? We're trained. I'm really good at sitting behind a computer using Stata and analyzing my data. That's what I'm trained to do. But I never was not as explicitly taught that next step as well. And so having the confidence, to go out and do press or to do things in lay language and to communicate and figure out how to make your results impactful and translate them is honestly a different skill set. And that's where partnering becomes another way to help. I think like my clinical associations, we're able to bounce things back and forth. They're hearing things from their patients that I'm not hearing that, generate the ideas. And I think having those conversations and the bandwidth helps to then inform and slow down the thinking that one person has and help have the perspective of what are those next steps? What are the questions being asked? What is the need? And then how do I do it? Of course, I have the benefit of working at such a large university, which makes it a little easier. If you walk down the hallways, that there are people doing different things and if you ask for help, they are very generous with their time. So I think I've benefited from being able to walk down the hallway and ask a lot of people, how do you do that? What do you, there's all these amazing models of people, but it does require getting up out of your comfort zone and spending the extra time and energy to try to figure that out.
Yeah, it also speaks to getting back in person. People talk about the end of the pandemic, everybody's just going to want to stay home and work remotely, but it's those interactions that sometimes always only happen in person or around the water cooler or whatever. But
and it would, there's a million things I spent time on that had zero translational impact that didn't make it into the talk, right? Of course, which is part, so there's lots of things that you try that don't fly, but I think that's part of the process. So not to get discouraged and continue to just think about the right ways, and some of them will have that impact.
Yep, great. So we have a question from Gary Pierce. He says, great talk. Where do you want to go with all this expertise and capacity in the future?
Oh, what a big question. I've been spending a lot of this year, some of my extra work thinking about building of scientific teams within my cohort, because there's just an immediate need for that, and the coronavirus pandemic, because again, it's such an immediate need. So I have to be honest that I've had a less bandwidth to think about the next steps in the HPV and translation research, because it's responding to the urgency of my team's needs and the pandemic kind of have taken a little precedence. But for HPV-related oropharyngeal cancer, which most of my talk focused on today, I think that the next big questions are really helping to get HPV vaccination up, to figure out the best ways to screen, because we do not have screening for oropharyngeal cancer. And so, I have a big cohort that I didn't go into here where we're trying to look at what the right biomarkers are and what, people who have these persistent oral HPV infections for years, I really believe they are at increased risk, but we don't have any FDA approved tests. We don't know what their risk is, how to counsel them. We don't know how to surveil them. So there are a lot of opportunities to help identify those at risk.
Great. Good. I guess I'll throw out another question. Oh dear. I just went blank, but I'm back. We're building up our Center for Public Health Advocacy at the school. Have you started working with people in the area of advocacy, overall public health advocacy? Seems like a lot of what you're doing.
Yeah, I haven't. Chris Beyer was my faculty mentor, and he's such an incredible public health advocate and human rights advocate. And I've certainly had a lot of mentors in that space, but I haven't networked. I think so much of this is integrating yourself with the right teams, and I haven't done that piece yet. But once we're back in person, I look forward to doing that.
That's great. That's great. Well, fantastic. Well, we're just about at the top of the hour, and normally we would break and go to the Wall of Wonder and drink a toast to you and all the incredible work you've done. Unfortunately, we can't do that right now, but once we get back in person, we'll have to make a point of doing that. So thank you again for everything. All your contributions and your focus on translation and having an impact it's just incredible work. So thank you so very much, and thanks to our audience for participating. We appreciate your attendance, and we'll be back with another Dean's Lecture shortly. Thanks so much,
everyone.
Bye-bye.